Today I will be discussing two cases on nystagmus. My case 1, he was a 9-year male child presented with the complaints of unsteady eyes since early childhood. Base corrected visual acuity both was 0.8 on logMAR. The nystagmus was left beating high amplitude jerk type horizontal nystagmus with null point in a right gaze with left eye fixing. There was no convergence dampening. He had abnormal head posture. It was left western of approximately more than 45 degrees. Right eye was exotropic 45 prism diopters, and he has a positive family history, that is 2 sisters with similar complaints. This is the preoperative video. The amplitude and frequency is increasing on the left side. He is preferring the left western with a null in a right gaze. The right eye is exotropic. Here also the V pattern. This is the cover test being performed. In primary gaze, the frequency and amplitude of nystagmus was very minimal. This is the video of his siblings showing the similar type of nystagmus. He underwent a 6-muscle surgery to correct the abnormal head posture and squint. Right eye squint correction was done. Lateral rectus resection 9 mm and medial rectus resection 5.5 mm. With left eye lateral rectus and medial rectus TNR. With both inferior oblique myopia was done. Abnormal head posture corrected with the residual exotropia. There was no improvement in the visual acuity on post-op day 7. This is the post-op day 7 video. On post-op day 7, in fact, he was preferring the other side head posture. There is a residual XT. Three months after post-op, almost full correction of abnormal head posture, but the residual XT is there in the right eye. Provisional diagnosis was made that infantile nystagmus syndrome with right eye exotropia with abnormal head posture more than 45 degrees with amyloidea. So my questions to the panel: what can be the other surgical option in this case? Next question: as we all know, on VNG we can differentiate very well all types of nystagmus, but how we can differentiate clinically the INS with strabismus and FMNS? Child brought with the complaints of diminution of vision. Best corrected visual acuity right eye was 0.4 logMAR with Lia symbols with -3 diopter sphere, and left eye was 0.8 logMAR with Lia symbols -5 diopter sphere. Pupils were normal size reacting to light. Color vision was normal. The nystagmus she was having left beating, low frequency, low amplitude, horizontal nystagmus with no convergence dampening. Left eye was exotropic 50 prism diopters. Abnormal head posture, there is head tilt to the left and chin elevation was present. Fundus was suggestive of optic nerve hypoplasia. This is the video.
That's very typical with associated sensory system deficits.
Yeah.
You see the synoptic nerve dysplasia, many forms of retinal disease, kids with conic up gaze.
This was the MRI. This shows the axial T1 and T2 images. Normally, the septum pellucidum appears radiolucent, separating the two horns of the lateral ventricle. Here you can see there is absence of septum pellucidum.
Yes. So it's very common in SLD.
Here actually usually associated with the corpus callosum deficit, but the corpus callosum on sagittal section appears normal. And also T1 you can see the absence of septum pellucidum again.
That's probably what our left eye.
MRI findings were suggestive of absence of septum pellucidum with atrophy of the optic nerves and optic chiasma with low placed fornices suggestive of septo-optic dysplasia, or also called as a de Morset syndrome. The diagnosis was made the nystagmus of both eye with exotropia left eye with optic nerve hypoplasia with midline defects. So I would like to put the questions: what other investigations can be done in such cases?